Okay, so let's look at some specific areas. It'd be nice to say, okay, give me just a one-page blanket rule. Okay, cheat sheet for what test do I order? Unfortunately, it's not as easy as that. It does depend on the region of interest, and it does depend on the likely pathology. And the last point is actually significant because you have to have thought about what you think might be wrong before you send them along, because some tests just don't answer the question. And if you think about, okay, what do I actually think is wrong with this patient before you send them, you're much more likely to ask for the right test. Okay, let's look at MSK stuff. I've included MSK, even though I'm a neuroradiologist, because I do an awful lot of it, and because lots of mistakes get made with referrals. MRI is the best all-round test. If you had to order, for large joints I should say, if you had to order one test for a large joint, and by large joints I mean shoulder, elbow, wrist, hip, knee, ankle, MRI is the best all-round test. It gives you detailed assessment of the bone, the ligaments, the tendons, the menisci, the muscles around the joints. It also gives you objective imaging. Patient can take away the CD or the hard copy films, or it's available online for specialists to review, or for you to show the patients in a way that is you can actually identify abnormalities, and you can understand what the abnormality is. For instance, if it's pointed out to you, you can see a big tear in a meniscus, or you can see a bone bruise or fractures. Ultrasound relies on a report. Of course, we all know that an ultrasound picture is just this fuzzy grey thing, even means nothing to another radiologist most of the time. And it's also relying on sonographer skill and a radiologist skill, depending on hands-on scanning, the skill of those people. You can't verify it any other way other than doing either another ultrasound at another site or another test like an MRI to verify it. Ultrasound can't tell you about bone contusion and subcortical fracturing, both very common things in acute injuries. It can't tell you about the state of articular cartilage. For instance, osteochondral lesions, think of the talar dome in an ankle injury, post-traumatic degeneration and wear. It can't tell you about the acetabulum of the hip. It can't tell you about the glenoid labrum in the shoulder. As I've said, you can't see the cruciates or menisci. And you can't see all the ligaments either, particularly ankle, elbow, wrist. And it's also very insensitive for low to intermediate, but particularly low-grade muscle sprains. You can do an ultrasound of a quads tendon and somebody who's telling you they've got what feels like a cork fire, but unless there's a hematoma there, you won't see it. Conversely, for small joints, ultrasound rules. It is by far the best. Fingers and toes, love ultrasound. For tendons and lumps, capsular and ligamentous injuries, for dynamic assessments, for instance triggering, for tenosynovitis, ganglia, small tumours. I've got a lump on the palm of my hand or on the top of my finger. In the feet, Morton's neuromas, intermetatarsal bursitis, plantar fasciitis, ultrasound rules, by far the best. It does require high quality ultrasound, particularly if you're looking at fingers and toes. You need to have high resolution, what we call like hockey stick scanners, which are about that big. And you need to be able to have a good knowledge of anatomy as well. Once you start looking at, for instance, collateral ligaments of the thumb and all that sort of thing, you need to have quality radiologists, quality imaging, and also quality sonographers as well. Sometimes we use MRI for things like plantar plate injuries in the digits, and particularly looking at ligaments in the thumb, particularly in people who may have had prolonged problems and you're really wanting to go back and see, are we missing something here? Perhaps, the ultrasound showed a lot of hematoma at the start and you weren't too sure what was going on with the collateral ligaments. The problem with MRI of small parts are that, particularly on 1.5 Tesla scanners, spatial resolution can be an issue, and you really need a highly cooperative, motivated patient to get good quality MR imaging of digits because they're so little that you can end up with just a fuzzogram and you're not really sure what's going on. So here's an ultrasound of a flexor tendon, which beautifully shows, this is the tendon itself, which looks quite normal. This is the tendon sheath, which is grossly abnormal. It's bunched, it's thickened, it contains a lot of fluid, and there's even some debris here. And the beauty of the ultrasound is that you can see that sheath, and then you can get them to actually passively and actively flex during the examination. You look at what's going on and you can see, is the tendon triggering, is it catching, are the pulleys thickened as well as the sheath. You get beautiful functional information that isn't available any other way. Okay, let's get to the shoulder. We'll go through the few modalities and I'll tell you where I think their places are. Plain films. We do lots of plain films of the shoulder and it's a good test. I think plain X-ray of the shoulder is a great place to start. And it's also one of those things that you work in conjunction with the other imaging that's of use as well. For instance, great way of looking at acromioclavicular and glenohumeral degeneration. You can type the acromion, so on the laterals you're looking if they've got a flat acromion, a curved acromion, or a hooked over acromion. You can see dystrophic calcifications in the region of the rotator cuff, which gives you a heads up instantly that they've got calcific tendonitis, even before you do any other more complex tests. Ultrasound, good for the shoulder. It's useful to screen for rotator cuff tears, biceps tendinosis and bursitis. Again, it gives you great, and it's the only way that you can get dynamic information, range of motion. For instance, the inability to externally rotate might point to adhesive capsulitis. There's no other dynamic way that you can get that information. And impingement, of course, dorsal impingement when you're abducting versus rotator cuff impingement. And that has extremely important information, extremely important information to give to treating physicians. You can localise regions of tenderness. Sometimes patients say, "Oh yes, doctor, it hurts everywhere," but when you actually put the probe on the spot of the long-headed biceps tendon, they go, "Ah!" You know that that's the bit that's actually hurting, because often they're a bit vague at the start of the examination, and then when you're going through the particular areas, you can actually clearly identify what's the cause of the symptoms just by pressing on it. Again, you can't see the labrum, you can't see the intra-articular long head of biceps, which is commonly affected with tendinosis and tears. And you only get a view of the top of the AC joint. So, but really, as far as AC joint, it's the bottom of the AC joint that we're really interested in, because that's the bit that sticks into the tendon and causes impingement and tears. You can't see that on ultrasound. Also, it's less accurate than MRI for characterisation of tears and tendinosis. Sometimes it just all looks dark and we're not sure if it's just a really prominent area of focal tendinosis or if actually there's a tear in there, particularly when you're looking at the deep aspect of the tendons close to the bone. Very limited bony detail, and it can be really hard in big people. Now, big can mean fat, but it can also mean big people with big deltoid muscles as well, or big, heavy set people with thick neck, heavy set muscles. Sometimes the rotator cuff just looks like a grey fuzz, and seriously, the sonographer is coming up to me and go, "I don't know," and then we think, okay, this would be a good person for an MRI. So all around, again, MRI, if you had to have a one-stop shop, that's the best test, and it gives you information about all of those things. CT, I would say no role for CT in imaging of the shoulder other than orthopaedic preoperative assessment. This was a case from just the other day I picked up. This is an ultrasound of the shoulder screening for pain. And you can see here, this is, well, it's a bit dark, but the humeral head is up here, and this is the humeral neck here. This is a view looking towards the posterior labrum, and there's this bulging black bit, and this is fluid, so but this isn't actually quite in the joint. And you're thinking, something going on there, but the rotator cuff looked okay, and there wasn't really much in the way of bursitis. So we did an MRI, and what we can actually see is this is a lovely looking rotator cuff, no bursitis, nothing thick or white under there, but there's this big thing sitting in here, and that is actually a spinoglenoid ganglion. And where does it come from? It's this little bright bit in here, which is actually the superior labrum. So there's a tear in the superior labrum, and they've formed a paralabral ganglion, and it's just grown and grown and grown, and now it's extending into the spinoglenoid notch. The MRI is the only way that you can see that labrum. Okay, what about the elbow? Plain X-rays, of course, query fracture, and for osteoarthritic screening. I should say plain films, usually for query fracture, it's always where we start. I would never advocate that you skip plain X-rays if you're looking at acute trauma. With the exception of perhaps the large joints with the knee, for instance. Knee plain X-ray and acute trauma is not so exciting, but if you're thinking about fractured patellas and things, maybe. Ultrasound is really good for assessing the common extensor origin and common flexor origin, tendinosis and hypervascularity. You might be able to see if there's a joint effusion. It's quite good at looking at the ulnar nerve in the cubital tunnel, the posterior interosseous nerve. You get very limited bony detail. And as for the shoulder, on tendinosis, sometimes it can be a little bit hard to see the difference between tendinosis and little intrasubstance tears. And you can't assess the ligaments on ultrasound of the elbow. Again, MRI, one-stop shop, best all-round test. Except common extensor origin tendinosis and complex origin tendinosis is an easy clinical diagnosis, isn't it? The patient can come with a really strongly suggestive history, Clinically, you just know what that is, but perhaps you just want to document how extensive it is. Is there a tear there? Is there something that might be suitable for a steroid injection? In which case I would say ultrasound is the way to go. It's a targeted examination, that's all you need to see, that's all you need to do. So here's that example. So on the right here, this is some normal looking tendon fibres of the CEO. If you look on the left here, this has been beamer imaging. It's thickened, it's got patchy hypokineticity. You can see a bit of bony spurring on the edge there and some more bony spurring here. And then when you put the colour box on, it lights up like a Christmas tree. But you can see how dark it is in there. It would actually be quite hard to miss a little, because they're linear tears often in the intrasubstance bit, and they just look more black than the other areas. It would be quite easy to miss one. And it's significant to know whether there are tears there or not if you're going to blast some steroid in there, because you have to be very careful not to make a tear twice the size by sticking a needle in it and injecting a mil of steroid. What about the wrist? Again, X-ray, great place to start. Ultrasound is great for tenosynovitis at the wrist, the querr veins, don't need anything else really, very easy, gives you functional information as well. For lumps and bumps of the wrist and in the hand, ganglia, similarly, ultrasound is great. For an initial assessment of the median nerve, do you want to see if they've got carpal tunnel? You want to have a look at the median nerve. Is there something squashing in the median nerve? Does the median nerve look normal or not? Ultrasound is fine. However, if you want to look at the tendons, or if you're thinking they might have TFCC problems, if you have some reason to think that they've got an intrinsic or extrinsic ligament injury, so sprain injury with ongoing symptoms that doesn't seem to be settling, MRI is the only way that you can assess the ligaments of the wrist. Bony changes as well, you get more information, obviously very limited information on ultrasound, and of course a rebated indication for scaphoid fracture is to do an MRI of the wrist to have a look. You can do CT of the wrist to look at fractures, and I think CT of the carpus to assess for are there little avulsion fragments is actually a good test. Just occasionally, and it would be rare, it'd be a minority of time you might miss, or we might miss, a completely undisplaced fracture in the carpus on CT. It can be trickier than you think, but most of the time CT is a good second line. MRI, if there's no bone edema in a carpal bone, there is no fracture. The one exception would be, which is what you actually, CT is good for, is the tiny, tiny little avulsion fragments that sometimes people get that don't really cause edema in the central bit of bone, but it can cause symptoms and lumps and things to feel as well. So here's an example. This is a sort of oblique, so I have trouble getting a true lateral. This is an oblique view of the carpus, and you just see there's a tiny little bit that seems to be out of place there. But who knows where it comes from? Well, is it that this is a lunate here? Is it popped off there? There's tracheal here. This is scaphoid through here. Kind of hard to see where it's coming from. The radius and the ulna look okay on those views. So here's an axial CT, patient got a back slab. This is the triquetral, and you can see that there's an avulsion fragment from the dorsal aspect of it, and that married up with the plain film findings. So that's all you would need to do to diagnose that fracture in that patient, only an MRI. On the converse, here is an MR. This is pixelated, I apologise, but this is a fat saturated coronal gradient echo image, and you can see here, line 3, you could see that there's a bright line through here and that there's bone marrow edema in that scaphoid. But you can see the cortex is absolutely perfect, it's completely undisplaced, and that's why they can be so hard to see on plain films. What about the hip? Plain X-rays. Plain X-ray for the hip is a great test. I'm always happy to report a plain X-ray of the hip. It's great for screening for osteoarthritis. It's never a waste of time because it's actually useful even if you have an MRI, because the little os acetabulae that are of use to specialists, for instance, if they're working out whether they're going to be doing further treatment, say for people with labral pathology, the os acetabulae can be hard to see on MRI. It's also nice to see the degree of sclerosis and cyst formation on general plain films. It's perfectly good for screening for developmental dysplasia, for Perthes and slip femoral epiphyses, for the review of prostheses. Is there any change in the last year, even though they've got pain, is there a periprosthetic fracture, are there signs of loosening osteomyelitis? It's a great test, plain X-rays of the hip. MRI is the only test that we can do to assess the acetabular labrum, and often the labrum is relevant when we're looking at the extent of osteoarthritis and femoroacetabular impingement. It's the only test that we can reliably diagnose, or that's not true, I shouldn't say the only test, but it's because you can do nuclear medicine as well, but it's, I would say, the best test because you're not irradiating the patient to diagnose early AVN and to look for occult or stress fractures, transient osteoporosis. It's also great for looking at the gluteus tendons. Again, you can look at ultrasound, and you can look at, get an idea if there's gluteus tendinosis and tears on ultrasound. But sometimes, and unfortunately, the classic patient who comes for trochanteric bursitis ultrasound is big, overweight female who has lots and lots of fat in the area of interest, and it ends up that the gluteus tendons are this like grey fuzzy thing at the bottom of the picture, and you're really not sure if there's a tear there or if it's just tendinosis. So MRI is more accurate in determining whether there's actually a gluteus tendon tear there. Hamstring origins, iliopsoas, piriformis, all the muscles around the hip that can cause problems as well. Sometimes ultrasound is all you need for the trochanteric bursitis. Again, it's one of the ones like common extensive tendinosis. It's clinically an easy diagnosis to make. Sometimes, do you really even need an ultrasound at all to make the diagnosis? I'm not sure that we add anything sometimes other than we put a probe on the spot where we know the tendons are and they go, that hurts, and that's kind of the diagnosis, which you sort of do in the clinic as well. CT, again, I would say CT of the hip doesn't give you any more information than a plain X-ray, and you shouldn't be ordering them except if it's a preoperative workup. So this is, again, a hot off the press case that I had just my clinic out at Epping, and you can see this is a 43-year-old man who had months of left hip pain. This is the little osacetabulum that I was talking to you about before. These are often seen in the setting of labral pathology. They're a little bit of a heads up that there might be something else going on. But overall, his hip doesn't look that bad. The joint space is good, the congruity is there, can't see any big overhanging osteophytes, there's not any craggy enthesopathy of the trochanteric, of the radial trochanter. Not too much going on there, you might think. This is an MRI, which shows he's in all sorts of trouble. So basically, this is a fat-saturated sequence, so normal, happy bone marrow looks like this, black, because it's full of fat. This entire femoral head and the neck is grossly filled with edema, and these subtle little linear black bits just beneath the cortex there, they're micro-stress fractures. And this fellow had transient osteoporosis with stress fracturing, a really good reason to have a sore hip that you can't see on a plain film. What about the knee? Plain X-rays. Again, a great test. Plain X-ray of the knee. Sometimes they get forgotten. We get a patient that comes along for an ultrasound of their knee, and I go to the sonographer, are they getting a plain X-ray today, or have they got one that I can look at? No. Okay. Osteoarthritis screening, weight-bearing alignment, patellofemoral joint views give you a lot of information about what's going on in the knee. Again, if you have to have one test for the knee, MRI is the best test. It tells you about osteoarthritis, it tells you about meniscal tears, the cruciates, the collateral ligaments, the extensor mechanism. In setting of either acute injury or chronic symptoms, it gives you just about everything that you need to know. The only thing it's not going to give you is some functional information, and that's one scenario where here CT might be indicated. For instance, we can do CT imaging in various degrees of extension and flexion and look at patellar tracking. But that really is a problem-solving exercise in a very specific set of people. Generally speaking, you wouldn't order a CT of the knee to assess for, to investigate pain, for instance, or instability. Ultrasound of the knee is one of my biggest bugbears. I get asked to do so many of them, and I would say probably maybe 50% of them are actually strongly indicated. It really has a limited role, which might be targeted to tendinosis of the patellar and quadriceps tendons. And if it's clinically patellar tendinosis and you want to document the extent of patellar tendinosis, absolutely appropriate. But more often it's more nebulous pain around the place, and wondering if there's sprains or if there's other pathology going on. If there's a lump in the knee, is it a Baker cyst, is it a fusion? In which case, ultrasound might give you a partial answer, but not the whole answer, as I was talking about before. What about the ankle? Again, plain films, good for the setting of screening and setting of acute trauma. Ultrasound is quite good for tendon tears and tenosynovitis, but it's a limited assessment of the ligaments, particularly in the acute setting when you've got lots of edema and bruising around when they've had a sprain injury. It can be quite hard to see what's going on with the ligaments. And the only ligaments you can see are ATFL, the anterior syndesmotic ligament, and CFL. And CFL is often really hard to see. These are the most commonly involved ones in a sprain. And usually if there's a gross injury and it's totally disrupted, you can see. But grading a partial thickness tear, is it really a high grade, almost complete, or is it like a fairly minor sprain, can be quite difficult in the acute setting. And again, you might get some information about, is there a joint effusion? But you're not going to get information about all the other things that it might have done to their ankle. And in the first instance, that thing where it might be appropriate to wait and watch. In ankle sprains, I would say, yep, reasonable to get a bit of an ultrasound at the start to sort of give you a rough idea about the extent of the injury. Just looking at the ankle might give you that as well, in terms of the degree of bruising and swelling and deformity and the history and the time since the symptoms and how severe the symptoms are. I wouldn't recommend that patients should be having an MRI acutely, but if they've got ongoing symptoms, if they're not settling, if they've got pain, or if they're starting to talk about things that make you think, is there instability there, then think about doing an MRI. Often we get patients referred for MRI because they're just not settling, and in actual fact, 6 weeks down the track we do the scan and they've got bone bruising all over the place, or they've got an osteochondral lesion of their talar dome which you can't see acutely until it's really late down the track and you do a plain x-ray and go, whoops, missed that one, because the cartilage is all gone now. So, and the other thing is other ligaments that you can't see on ultrasound, the spring ligament, the ligaments in sinus tarsi, impingement syndromes that occur after ankle sprains. These are all best imaged with MRI. Again, CT of the ankle, pre and post-op assessments only. For missed fractures, I think, I would say for the ankle, no. For the midfoot, yes. Midfoot fractures can be hard to see on plain x-rays sometimes, little fragments, undisplaced fracture of the cuboid, things like that. So I'm happy to do CT to look for fractures in the midfoot in somebody who's not settling. But you get all that information on MR as well, plus all the other stuff with the ligaments. Yes?
Just about the Achilles tendon, what can you do regarding ultrasound?
Achilles is actually, ultrasound is good for Achilles tendon, yes. Happily see that as a screening test. If you want to see, is there increased vascularity, are there tears, is there retrocalcaneal bursitis, more than happy to do ultrasound. MR simply gives you all the same information. You could choose depending on if the patient had more than one thing going on, but if it's straight up Achilles, more than happy to do ultrasound. Okay, let's move to the spine, cervical spine. Neck pain plus symptoms and signs of radiculopathy. Arm pain, paresthesias, weakness, wasting. MRI is the first test. And this is a rebatable scan. Patient doesn't need to be out of pocket for this scan. It is the best test. It is far better than CT to show cord pathology, canal stenosis, exudating nerve root impingement. You really should be doing only CT and cervical spine, and I mean in young people and old people, not just young people here, everybody. You should only be ordering a CT of the cervical spine in someone with radiculopathic symptoms if you're really doing workups for assessment of bone effusion, if there's question of acute trauma. Plain x-rays, they're kind of a basic first-time screening tool. They don't give you a lot of information. They give you a bit of an indicator. Scoliosis, standing AP views, plain film is kind of useful. People have vague, non-specific pains whether they're young or old, and sometimes the only abnormality they have is a bit of degen, but then a scoliosis, which can be related to multi-level pain in their spine. And of course, dynamic flexion extension views for instability. So if your spine looks like this on plain x-rays, are pretty much a heads up that there's probably going to be a lot going on. This poor old lady had radiculopathic symptoms, and I think you'd agree that you don't need to do any other test to see that there's clearly going to be significant pathology in her cervical spine. She did, however, she fell out of bed at home, and somehow she ended up on a CT scanner, perhaps because there was a concern about, given her age, I think she was 80-something, that there could have been trauma in the scenario as well. So she had this CT, and she's a bit scoliotic, so it's a bit hard to follow what's going on. And at first glance you might go, okay, there's a bit of degen there, yep, all the discs are narrowed, sclerosis, but if you look very carefully, there's actually a bit of a slightly dense area back here, but you have to say, wow, it's a bit hard to see. This is the cord in the centre, and there's a bit of a dense area back here, and then it just sort of looks grey down there. Not sure what's going on there. So then she had an MRI because the radiologist got a bit suspicious about why it looked a bit brighter at the back of the canal, And on the MRI, we can beautifully see that in actual fact she's got an acute epidural hematoma that is compressing her cord from the back. And this was only a fall, from ear to ear out of bed onto the floor. And so she's got a cord compression from an acute bleed, and add a little extra, she's got a tumour in her canal, which when you go back, that is exactly where it is, it's in there. Whoops. And then you come here, oops, sorry, and there's absolutely no way you can see that except on the MRI. This is the same patient, an axial, so this is the axial from the CT, which now that you know it's there, you can kind of see the epidural hematoma, but you could be forgiven for missing it if you're just having a quick look. And here it is on the MRI. This is the dura squashed forward with blood behind it, squashing the cord. It's very easy, isn't it? So it shows you what the difference is in the ability to diagnose. Thoracic spine. I hate CT of the thoracic spine, just let me tell you, get asked to do a few of them. It's a terrible test. Don't order CT of the thoracic spine unless you're really wanting to characterise traumatic fractures. MRI, great test for the thoracic spine. If you want to assess osteoporotic fractures in terms of are they pressing on the cord, are they new or old, is there edema there, are they osteoporotic or is there something sinister underlying there if you're looking at fractures. Of course, plain films are wonderful looking at thoracic spine if you've got a reference point. You know that in 1989 they had 3-level osteoporotic fractures and they've got new pain, then perhaps the first best port of call is a plain x-ray, and then you compare with the old, and all you need to do is say, yep, they've got a new level that's fractured, and then you've got your answer. Never underestimate plain film role there, it's great, and we always want to see the old ones if possible. Lumbar spine, back pain with radiculopathy, all ages, MRI is the best test. Yeah, it sounds like a broken record. I don't have any shares in the MRI scanners. I don't get paid any differently as to which modality you use, but it's just a fact of life. CT in the lumbar spine is a good test. I don't mind reporting CT in the lumbar spine. It gives you a lot of information about what's going on in someone's spine. But it's a significant radiation dose to the pelvis and to the gonads in a patient. So think about not ordering a CT if the patient is younger, because the relative dose that's given to somebody does depend on where you scan them. So CTing somebody's brain gives you a much less significant dose to the radiosensitive bits, which are your ovaries or your testes, than CT of the lumbar spine, which blasts your pelvis and all the bits that are close to it. So, and MRI is better anyway. So if you order a CT lumbar spine in a 30-year-old, and I do lots of those, sometimes I get tired of reading on the phone and say, you should really do MRI. But if you're ordering a CT, you've got to think, well, in actual fact, I could order a test that doesn't have any radiation for this patient and actually gives a better test and better answer anyway. But notwithstanding that, in a case where CT is less of an issue, an older patient, it's a good test, and I don't object to reporting them. Back pain in young people without radiculopathy, MRI is the modality of choice. Sometimes it's muscular, and of course if it's muscular we're not going to see anything, but at least you haven't irradiated them for back pain with no radiculopathy. And again, we get requests, CT for back pain in a young person with no neurological symptoms. That distresses me because it's a significant dose. Discogenic pain, Haas fractures, Haas defects with stress fractures, spondylolisthesis, these are all things we commonly see in young people with back pain, and they're significant to diagnose. And of course you may have done a lumbar spine plain film and diagnosed the spondylolisthesis, in which case you don't need to do a CT to diagnose it. You may want to do an MRI, however, because they've got bilateral L5 radiculopathy and their exit foramina look like pancakes rather than nice round holes. Some people just have the shape of the lumbosacral junction reduced offset that leads them to premature degeneration, and I see pretty nasty looking discs even in people who in their early 20s if they've got reduced lumbosacral offset, for instance, or if they've got Haas defects. When should I order a bone scan? I'm going to skip over this, it's in your notes. Basically, there are some indications where bone scan is the best. Sometimes you can also get an MRI, for instance, stress fractures with negative plain films, differentiate cellulitis from osteomyelitis. So if you would like a copy of a printout of this talk, you're more than welcome to get one. And you can just approach us at the end and give us your email address or something like that. We would be more than happy to furnish you with a copy. Evaluating prostheses and workup of focal bony lesions. Okay, I've got a few comments on image-guided therapeutic injections because these are called a source of confusion as well. quite often, well, I wouldn't say quite often, sometimes I get a request and it says CT-guided steroid injection lumbar spine. I'm not kidding. Or it might say CT-guided nerve root injection left side lumbar spine. And I'll be like, okay, I'm going to have to start from the beginning with this patient and take a history, examine them and figure out what level and what anatomical site and all that sort of stuff. And sometimes that's fine, I can do that, and sometimes it's really hard. The patient doesn't speak English, and the mother hadn't come along, and they can't give a reliable history, whatever it is. So there are different anatomical sites that we target with steroid injections of the spine. They're completely different, and it's worthwhile knowing you need to be specific in what you're requesting. In the Australian Financial Review, some of you may have read recently, there was a full-page article talking about how translaminar epidural steroids do not work as a general thing, and they were talking about for back pain, and I totally agree. I'm very happy not to do translaminar epidural steroid injections for people with discogenic back pain as a general rule. I do them sometimes for people with significant canal stenosis, particularly if they've been worked up for surgery and they're either waiting for surgery or they're not a candidate for surgery. And sometimes I do them in post-operative patients with failed back syndrome where there's just no other option, so it's worthwhile giving them a chance with some steroid. And I do have some frequent flyers that come along 3 or 4 times a year to have their epidural steroid, and they claim that gets them through, and I'm happy to do that for them. Where it's more useful is if someone has a unilateral and specific sciatica. We're much better at treating the nerve compression than we are the back pain. It's very hard to treat back pain with steroids. So there's 2 ways of approaching a nerve that's compressed: transforaminal and translaminar epidural. And it depends on whether it's a foraminal compression or a central compression. So if the disc bulge is midline, for instance, it's squashing the L5 in the centre, then doing a translaminar the level below is not likely to be as helpful as doing a transforaminal the level below is not likely to be as helpful as doing a translaminar at the right level. Facet joints, I'm happy to do bilateral facet joints steroid injections at 1 level, particularly in the lumbar spine. They can last that. You can do 2 at the same time. More than 2 at the same time is generally too much for the patient. And sometimes I get asked to do 4 injections in 1 hit. It's too much for the patient. And also you're clouding the part of the use of steroid injections is diagnostic. So if they get a good response, even if it's a short-term response, if they said, yeah, it was really good, even if the local said, yep, that took the pain away, that for 6 hours, that's what I've been talking about, and for 6 hours I was pain-free, you've got the right area. Whereas if you start doing multi-level in 1 hit or within a couple of days of each other, you're really clouding where the pain or the symptoms are coming from, and one of the uses is a potentially diagnostic use. So be specific about the anatomical site that you want, and be specific about the levels that you're interested in. And if that's unclear, then pick up the phone and have a chat to the radiologists who might be going to do the procedure for you. Cervicals, these are facets, same kind of rules, although I'd say for a cervical facet you have to lie on your side. So to do 2 levels is much harder than in the neck than it is in the lumbar spine, because you have to do all the planning scans in 1 position, and then you do that, and they usually don't like it very much because your neck's more sensitive than your low back. And then you have to kind of pull everything off, get them to roll around on the other side, and start again on the other side. It's much more prolonged, and often they're sort of ready to sort of say thanks, see you later after the first one. Nerve roots I only do in conjunction with specialist referrals because there is a risk of death from stroke, cord hemorrhage, and that is not, it's rare, but it is not unheard of. There are multiple cases in Australia and around the world, case reports, but also in recent times, even using good technique, that can have catastrophic complications because of where the vertebral arteries are, and also the branches of the vertebral arteries are really close to where you're going. Steroid, other than dexamethasone, is particulate, and if you accidentally inject a little bit of particulate matter into a tiny radicular artery that then is supplying part of the spinal cord, you can cause a cord infarction or posterior circulation stroke, which can be catastrophic. So I have a high threshold for doing them. I screen the patients very carefully, and usually it would be in conjunction with a neurologist or neurosurgeon, so that you know that it's very strongly appropriate. And they have to have had an MRI before the procedure, so that you can see where the vertebral arteries are sitting in relation to the nerve roots. MSK therapeutic injections, a lot of these can be done under ultrasound, and that's fine. Hip joint and shoulder joint require fluoroscopy. Some radiology practices will do them. Not a lot of practices actually have fluoro machines now. They're not installed. They're very expensive. They've never pay their way, if you like, and there's also a lot of alternate tests that give you the answer. So a lot of sites don't have fluoroscopy, so it's disappointing when a patient turns up and they want their hydrodilation of their shoulder and it's at a site you don't even have fluoro machines, so you can't even fit them in, you have to send them somewhere else. That's quite frustrating. Those two tests can be done in the CT, but it's a higher dose to the patient to do both shoulder and hip hydrodilatations or steroid injections under CT than you need to. So, you know, it would be better for the patient to actually go to a site that has fluoro and have it done in the fluoro than under CT. CT is great for sacroiliac joints and for small joints in the midfoot if you want specific. You can tailor exactly where the tip of your needle goes. It'd be a bit hard to see exactly where it goes on ultrasound, but you can do it under ultrasound as well.